God dag alle sammen. I have to turn to English, but I would like to speak Norwegian with you. It's really nice to be back in Iceland again. I was here about 7-8 months ago. And we have heard these lovely presentations about theory. We have seen the videos and how to do therapy. And I'm going to present more practical work. How we are working with early intervention in Norway. And to identify and support infant and families at risk. So the outline. First, I would like to share with you some relevant facts about Norway. More than that we are good skiers and that we're not part of the World Cup in football, like you are. Congratulations to you. And the organization of the infant mental health work in Norway, the strategy we use, topics for teaching and training, and some of our research topics. So some about the facts about Norway. We are a population of 5.2 million. We have now 15% immigrants, which has accounted for most of Norway's population growth the last years. And there's an increasing number from non-Western countries like Somalia, Pakistan, Iraq, and Kurdistan region, Syria, which means that we need more knowledge about cultural differences in the perinatal period, how to care for young children, what are parents' expectations about parenting, fathers' roles, all these things. We have about 1 million children below 18 years, 60,000 births per year. A total benefit period for parental benefits is 49 weeks at 100% coverage, or 59 weeks at 80% coverage. So 10 weeks of the paternal leave is devoted to fathers. They can, of course, decide how much they would like to share, but most fathers are home with the children from 9 months of age of the children. So then we see the fathers in the well baby clinics. That's also a topic, how to integrate, welcome fathers, how to support fathering in the early years. It's a new area that we have to work with. And fathers may have 2 weeks free from work, the 2 first weeks of the infant's life. And now about 90% of all children between 1 and 2 years are in daycare or nursery. I heard in Iceland there's no nursery or daycare for children before age 2, is that right? No? Pardon? Some. Okay. So this is also a topic because we hear that the professionals that work in the nursery, they say we lack knowledge about how to support the young children. What are our roles? We used to think of pedagogic, but now it's more about relationship, to be attachment person when the mother and the father is not present during the day. We have well baby clinics in every municipality in Norway. They are free of charge, and we reach 98% of the target population, which is very good. The aim of the well baby clinics is health promotion and prevention. And the staff there are midwives, public health nurses, GPs, pediatricians, and physiotherapists. The psychologists, they are not optional, but we're working on that. We hope to have those in the team as well. They offer minimum 1 home visit after birth, the first week or so, but we have Norwegian guidelines that says all families should have a minimum of 2 home visits during the first week after birth, and at-risk families should have at least 3 home visits the first month after birth. So that's the guidelines, but the implementation is not there yet, and we don't have the resources to provide this yet. And we have minimum 8 health checkups during the first year of the infant's life, which is a great opportunity for health promotion and preventive work. As in other European countries, we have about 6% premature births. We have 15 to 20% of children that have mental health problems between age 3 and 18 years. This is mental health problems. It's not disorders. So about 8% of young school children have a mental health disorder. We have recently found that between 5.7 and 7% of infants between 4 and 12 months have indication of developmental delays. A substantial increase of young children in the child protection services. And in the CPEs, there are few evidence-based interventions for this specific risk group for the youngest children. So what they offer is financial support for these high-risk families, free access to daycare, and weekend foster homes. So more external support and infrequent use of relationship-based intervention, which is what these families really need. They need to know how to provide nurturance for the children. A recent study conducted in Norway found that foster children between the age 6 and 12 years have a high prevalence of mental disorders compared to general child population in Norway and to other societies. And 1 in 2 foster children presented with a mental health disorder with high rates of comorbidity. And exposure to violence, serious neglect, and the number of prior placements increase the risk for mental disorders. And we know that quite few of these children get services from the child and adolescent psychiatry. Even if you have these good paternity leave systems, we have 10 to 15% of new mothers that have moderate to severe depressive symptoms in the perinatal period. So similar to other European countries. And it seems that there is an increase in the prevalence of mental health problems among women in this period. And we have also found that there are significant higher prevalence of perinatal depression among non-Western women in Norway. When it comes to depression in this period, we know that 1/3 of these women, they have had a history of depression. And 1/3 of them have depression also in pregnancy. And 1/3 develop a depression postpartum. So it's so important to ask about mental health issues when we meet the women during the pregnancy, so we can support them, so they can be best prepared as possible to take care of their child. And we talk a lot about mothers, but recent studies from Scandinavia shows that also fathers have depression. It's not a result, perhaps, of having a child, but fathers also can become depressed. So studies indicate that 8 to 10% among new fathers also suffer from depression. So we need to pay attention to the fathers as well. So postnatal depression is common and has negative effects of the mother-infant relationship and child development. And we know particularly is this the case when it is severe and chronic. Effective interventions are required to prevent the child's exposure to the more serious maternal depression and the associated parenting difficulties through the first 2 years in order to prevent adverse child outcome. So, monitoring of maternal mood should continue beyond initial postnatal screens. We know that we often screen the few first months after birth. We should continue screening so that further support can be provided if required. There are large gaps between what is known and what is done. We have this knowledge, we all know it, but do we change practice? So bringing contemporary studies involving pregnancy, birth, infancy and toddlerhood together, along with the undisputed evidential findings that flow from them, large gaps between what is known and what is done is apparent. So now it's need to focus on what can be done to fill those gaps. So the two presentations before me have talked about the critical 1001 days. Everything that is taking place from conception to the child is 2 years is so critical. The children's earliest years, the ones that matters most, do not start with the birthdays or even from birth, but from conception. We have to bear that in mind. The first 1001 are critical because they take a person from potential to actual, from conception to the second birthday, and it's during that period of fetal development, infancy and toddlerhood, that the brain is growing and developing with maximum and astonishing, as we have learned, speed that renders it more open to and dependent on outside influence that it will ever be again. And the outer influence, the environment, what is the environment for the infant? It is the relationship with the parents. So everything we do is really, we have to work with the relationship. You can't treat the infant alone. There's not such thing as a baby. It is the baby in the relationship. So the parents represent the environment nurtured by parents. Is hardwired into children's brain for good and for bad. So you saw this figure earlier. So the adverse childhood experiences, it leads to disrupted neurodevelopment, social, emotional, and cognitive impairment, and what follows from this? Adoption of health risk behaviors, which causes disease, disability, and social problems, and early death. So this is the background for early intervention. And we got nice help from James Heckman, who got the Nobel Prize in Economy in 2006 for showing this nice figure, telling us that early childhood development is a smart investment. That's the language the policymakers and the politicians like to hear. That makes them do changes. And we see that what we know is that most of the intervention is taking place in the school age years for the children. But if you really want to invest the money the right way, we should start not from birth, but from the very start, from conception, or even before. Same, put a more clear picture. Okay, so this is the background, and based on all this knowledge, we succeeded to establish a national network for infant mental health in 2006. We worked for many years talking about, showing these numbers, talking about these issues, arranging conferences, inviting policymakers and politicians to open our conferences, to give a talk. So they have to relate to the topics. And as you see, we got funding in 2006 when James Heckman got the Nobel Prize in Economy. So that was very, very helpful. So we're really happy about that. So this national network is commissioned by the Norwegian Directorate of Health and the Ministry of Children and Equality. Our main responsibility is to increase awareness of the 1001 critical days and for strengthening services for infant mental health in Norway. We have 15 positions and some PhD students with external funding in this infant mental health department. And from 2015, we got some extra millions to test out the Nurse Family Partnership Program, which is to support high-risk mothers or families from early pregnancy until the child is 2 years. In this system, we work clinicians and researchers together. So we make sure that we have the newest knowledge and we know how to integrate this into clinical practice. So we have midwives, public health nurses, psychologists, family therapists, pedagogues, and soon we will have a medical doctor as well. So, the main objective of this infant mental health service is to support public health services to identify pregnant women and infants and parents at risk and to provide early, effective interventions. Always say, babies cannot wait. To strengthen the collaboration between the primary care and specialist level, when we do training among health providers in the primary care, we have to include also professionals from the specialist level, because there will always be some infant and families that need more specialist services. To provide knowledge about the validity of screening tools. You know, there's so many tools out there, and who's the best? Who has the best psychometric properties? What shall we use? And suitable assessment and treatment methods for young children and their families. Again, we have a tendency to choose depending on some very good, convincing presentator instead of really looking to the evidence. What works? So we have to help out to choose the right methods. So what we do, we provide postgraduate training in infant mental health topics to health practitioners from all disciplines, nurses, midwives, psychologists, social workers, GPs, who want to specialize in infant mental health or child and adolescent mental health. We initiate research projects to test new assessment tools and interventions in a Norwegian context, because that's important too. Many of these methods come from, especially from the US, from other contexts, and we need to see if this is adaptable in a Norwegian context. And we implement evidence-based methods into clinical practice. And the definition of evidence-based practice is this one, which is based on these three factors. We have best evidence, but also clinical expertise, and not least important is patient values. We have to ask the patients what they prefer. It's so important. If not, we often see that we will lose the patients along the way. So that's our definition. So we see there are major gaps between what is known as effective practices and what is actually done out there. And when we do training, we have to lean on implementation research. And it says that the current gold standard of training in evidence-based practice typically includes a workshop, a manual, and clinical supervision to support behavior change. Very often we have the workshops. People really enjoy and like what they hear. Go home very inspired, with big plans to start implementing what they heard into the practice. But very few succeed in doing this if they don't get the clinical supervision. So it's so important to add the clinical supervision. And also key skills, are best learned at the job with the help of a coach. So it's not easy to change practice. We have to be patient and have to do all the necessary steps to succeed to change practice. So this just shows that very often we are in the middle. It says kurs, which is the course and supervision, but there's so much things taking place before. We have to plan. We have to talk with the leaders in the clinics so they are prepared to give time to support clinicians who's doing training in new methods, etc. And we need also to do a lot of work when we have finished the supervision. The maintenance seminars are so important to make sure that they continue to do the good work. So plan the training before, during, and after. This is the place where I work. This is the Regional Center for Child and Adolescent Mental Health, which is situated in Oslo, the capital of Norway, where we have the Infant Mental Health Department. We have 4 regional centers in Norway who's doing the same thing, who are funded by the Norwegian government. So we have the regional center in the east and southern Norway. We have in the regional west, the regional mid, and up north. So we have to cover the whole country. And it's a very long stretch country, as you know. So here you could just see an organization map that shows you where in the system are we. We have the Department of Children, Family and Equality on the top, Ministry of Healthcare Services, and the important directorate that gives us funding. And at level 3, we have the regional centers that support all clinics to do better services for child and adolescent mental health. And this is at the 3rd level where we are. And at the 4th level, we can see the different services that we work with, the NICUs, the neonatal intensive care units, and postpartum ward at the hospitals, well baby clinics, the daycares for the very young ones, infant teams in the child psychiatry, try to establish infant teams in all outpatient clinics for child psychiatry, and the child protection services. Okay, so we're translating research into practice. So the strategies. To do all this work, we lean on international support and collaboration. It's so important, and it was so nice today also to listen to the 2 of you, because feel that as long as we're working in the infant mental health field, we're all funded in the same theories. So it's very well integrated. There's no surprises anymore, I think. And that's really nice. So we have research and clinical networks like the World Association of Infant Mental Health, WIME, and the Nordic affiliation of WIME, which we would like to see that also you from Iceland could participate, but there are some barriers when it comes to language. because we try all to speak our own languages, which we can do, Swedish and Danish and Norwegian, but it's more difficult with Iceland and Finland. And we have the International Attachment Society, which is also very important for us, the Nordic Attachment Network, and the Marseille Society, which is doing research and clinical work in the perinatal mental health field. And the theory and research based on attachment and framework of the transactional model is what we are using. Continue to say over and over again, there is no such thing as a baby. We have to understand the baby in the relationship. But there's no such thing as a mother or father either. We have to really look at the baby. Who's the baby? What is the baby bringing? There's so huge individual differences. 1 minute? 10. Thank you. So we have annual, regional, and or national conferences about infant mental health and relationship-based interventions. In collaboration with these 4 regional centers and the local mental health services and CPS, it's very important for us to have local ownership and shared responsibilities. We always do it together with the services. We plan together. So that increased involvement and the ownership to develop this field. We have 1 or 2 day seminars and conferences for professionals working with infants and young children in daycare. And talk a lot about attachment and the importance of letting the child having an attachment person in the daycare. Always speakers from the national network and from the local services. And we have increasing requests for education and training in screening and assessment tools and programs for early intervention in both primary care and the specialist level. So by doing this, the requests are coming to us, that they ask for training. We produce reports, books, e-learning programs, and scientific articles. So it's very important for people in Norway to have Norwegian books, to have it translated, or to have people, professionals from Norway writing literature. That helps a lot. So that's something we do a lot. Areas of priority. We have to give some priorities because we have only 15 people and some extra now and then. So women's perinatal mental health is one of the prioritized areas, to identify and support at-risk pregnant women and their partner, so to screen for mental health problems and drug dependency, domestic violence and trauma, provide support and treatment in pregnancy and postpartum to the mother and to strengthen the infant-parent relationship. Another area is premature infants. We know they have high risk to develop problems later on. We know that a lot of premature infants stay in hospital for many, many weeks or even months. And in Norway, few parents have the opportunity to stay there because we have no family rooms. In some hospitals we have, some very few. But the child should have the parents there 24/7. So we support family-centered care in NICUs to promote healthy parent-infant relationships from the early beginning. We're supporting well baby clinics to identify at-risk infants. We want to reduce wait and see. There's too much wait and see. And vulnerable parents. So we support the public health nurses and midwives to screen for postpartum depression, to use the Edinburgh postnatal depression scale, and to become trained to do supportive listening, and to refer those with severe depression. And we support development of infant mental health teams in child psychiatry to build 0 to 3 teams. It's very, very important. So to the well baby clinics. So we implement the Edinburgh method. John Cox and Jane Holden developed the EPDS screening instrument. But it's so important not to only use the screening instrument. It's a whole package of knowledge that have to come with it. So midwives and public health nurses get 4 days training in perinatal mental health, and what is screening, how it differs from diagnostic work, and how to do counseling. We have done this now in about 300 municipalities out of 400 in Norway. This is something that the public health nurses ask for. We don't push the training on them. They come and say, after we have talked about this issue for many years, to say, we would like to do this work. We have monthly supervision based on interpersonal counseling by a psychologist for 2 years. So all midwives and public health nurses that use the EPDS, they get supervision. They have to have it for 2 years to know how to support. And to make sure that they will not do therapeutic work with women that should be in the specialist care. It's also important. And always, when we start this training, we invite also professionals from the specialist level. So they all know that from now on, in this municipality, the well baby clinics will identify more women at risk. So you, in the specialist level, also have to be prepared to support these women. So there's a collaboration. We have to build bridge between these 2 levels. We have annual maintenance seminars for those who are trained, and we have national and regional day seminars and conferences about perinatal mental health. We have a training program for 3 semesters at our regional centers. Midwives, psychologists, and psychiatrists are offered postgraduate training in perinatal mental health to improve support and treatment of pregnant and postpartum women with mental health problems. They come in for training 2 days per month. They have 1 day theory and 1 day clinical supervision. And we also have developed a postgraduate education program in infant mental health. A 2 years program for multi-professionals in primary care and specialist level. Again, 2 days per month, both training and supervision. So they have theory, assessment, and treatment methods. And they have a written examination at the end of the education. I'll drop this one. Okay, so then we just have to end by saying something about screening and assessment tools in well baby clinics when it comes to the children. So we talked about how to identify parents, but what about the children? The ages and stages questionnaire. Do you know this questionnaire? Yeah, it's assessment of the infant's general development. Gross motor, fine motor, communication skills, social skills, etc. Only 30 items questionnaire for children from 0 to 66 months. So they're age-specific questionnaires. I think it's about 20 different questionnaires depending on the child's age. It takes 10 to 20 minutes to complete the questionnaires, and it's the parents who complete the questionnaire. So what we do is that parents they complete the questionnaires before they come in for consultations. So then they come with a lot of questions and surprises and pride about what their child have accomplished. And also questions about, is it so that my child should be able to do these things now? And the nice things about these questions is that the response categories are, my child often do this, or my child do this now and then, or my child doesn't do this yet. So the nice thing about this not yet, is that it starts a nice conversation about what is coming up in the child's development, what are the next steps. And most parents will then start thinking how to support the child's development. Okay. The very last one is the Alarm Distress Baby Scale. I think it's very important to just say a few words before I end, and it's scale to identify infants with early symptoms of social withdrawal behavior, which can be used with children between ages 2 and 24 months. And this scale is so helpful because it's not difficult for us to identify these infants that are fussy, crying, making a lot of noise. But these infants that doesn't say anything, that come to the health control, they never say anything, they don't really protest when they have the injection or anything. So before the child is out of the door, we have forgotten about the child. But this instrument helps us to look at specific factors, and it's easy to use because you don't have to use anything else that you normally do in your practice. You just have to look for something particular. And this is, you look at the facial expression, the eye contact, level of activity, self-stimulating gestures, vocalization, briskness of response to stimulation, capacity to engage a relationship, and attractiveness. So when you're trained in this, it's more easy for you to think about this. How was this child when it comes to these aspects? And you can rate the child's responses. Give it a 0 to 4 rate, where 0 is no unusual behavior and 4 is severe unusual behavior. This instrument has helped a lot to identify these silent babies. And often we see that these babies with more persistent social withdrawal symptoms have mothers with depression. So it helps us to identify both mothers and children that need more support. Okay, so we have to end here. This was just a small taste of what we do in Norway. So thank you for your attention.